Good evening to all, and welcome you all to the Uromet 3.6. So, today our topic could be the discussing about the management of testicular cancer. I would like to introduce our expert panel. That is first Dr. Nishantali Patirana, consultant urologist currently working at the United Kingdom, and as well as Dr. Supundu Silva, again consultant urologist at United Kingdom. So, without spending much time on introduction, we'll straight away move into our presentation. So the first presentation would be the basics in testicular cancer and localized testicular cancer. Going to be present by Dr. Dunita Disanayake, who's a senior registrar in National Hospital, Kandy. So, Dr. Dunita, you will have 20 minutes for your presentation. At the end of 15 minutes, I will give a remind and you can present.
All right, thank you, Dr. Chaminda. Hope you can see my screen. Can you all see the presentation?
Yes.
Right. So I'm going to discuss the basics in testicular cancer as well as the management of localized testicular cancer. So, bit of epidemiology. As you all know, testicular cancer represents about 1% of the adult neoplasms and 5% of the urological tumors. So, at diagnosis, 1 to 2% of them are bilateral tumors. And out of these testicular tumors, 90 to 95% of them are germ cell tumors. So the peak incidence is about third decade for non-seminomatous germ cell tumors, and it's fourth decade for the seminomatous tumors of the testis. So 5% of these germ cell tumors, the primary site is extragonadal location. So next we'll talk about the risk factors. As you all know, history of cryptorchidism. Either side, it will increase the risk of testicular cancers. According to the evidence, 4 to 13 times risk is there if there's an undescended testicle, and 7 to 10% of the testicular tumors arising from these undescended testes, and 5 to 10% of the risk of contralateral testes as well. And if there's a family history of testicular cancer, especially from fathers and brothers, and it will increase the risk of testicular cancers by 6 to 8 times. So then the race, if these patients from Caucasians and Northern Europeans, there's an increased trend toward the testicular cancers. And they have shown that the maternal estrogen exposure will increase the testicular cancer risk in male offsprings. And if there's a history of subfertility, with the first semen analysis parameters also increases the testicular cancers by 1.6 times. So, and if there's a contralateral site, there's a testicular tumor, it will increase the risk of having testicular cancer by 5 to 10% risk in the remaining testicle. And they have shown that the HIV also increases the risk of seminoma, but the direct relationship is not aware. So let's go to the classification of histological classification of testicular cancers. Basically, we can divide it into germ cell tumors and non-germ cell tumors. So germ cell tumors, again, we can divide seminomatous, that is seminoma, and non-seminomatous tumors. So out of this tumors, about 40% are seminomas. So the non-seminomatous germ cell tumors are these yolk sac tumors, then teratomas, embryonal carcinomas, choriocarcinomas, and mixed germ cell tumors. Again, teratomas will have both ectodermal, endodermal, mesodermal origin, and there's a malignant transformation as well. So then non-germ cell tumors are these sex-cord stromal tumors. They are called Leydig cell tumors, Sertoli cell tumors, and gonadoblastomas. And apart from that, there will be carcinoids, adrenal rest, and mesenchymal tumors as well. So the classification is based on 2022 update on WHO pathological classification. The British Testicular Tumor Panel Registry also gives the same sort of classification. There's no much difference. So now let's see the diagnostic evaluation. So if you encounter a patient with a testicular lump, so you have to do a thorough physical examination. So they might present as a painful testicular mass most of the time, and there may be a history of recent onset laxidocele sometimes, and it might be an incidental finding on the ultrasound scan. Sometimes pain, either scrotal or abdominal back, may present. They will present as pain. So out of the testicular pain patients, 20% of them are having uh, testicular lesions. So, and sometimes they might rarely present with gynecomastia. And so therefore the clinical assessment is important. The external examination, the abdomen for palpable lymph node masses, and you know, chest and supraclavicular area. So sometimes these patients might present with advanced disease with the metastatic symptoms, with a retroperitoneal mass and neurological symptoms like pain, sometimes pulmonary symptoms as well. So next, the most important thing is the investigation part. So we have to go for imaging first. So we have to look for the primary tumor as well as the metastasis. So for the staging. So in primary tumor, we look for the confirmation of the presence of the mass and determine whether it's intratesticular or extratesticular and the size of the mass and anatomical location, and especially the characteristics of the contractile site. So first line investigation is the ultrasound scan of the scrotum. And then for the staging purpose, we go for CT scan, CCT, chest, abdomen, and pelvis. There's no added advantages of doing MRI over CT scan unless there is contrast allergy. So for the first line investigations, this PET scan is not included in the first line staging investigation. And the most important thing is testicular cancers is the serum tumor markers. So the tumor markers are assessed preoperatively as well as after this orchidectomy. So these tumor markers are important in diagnosis and staging as well as prognostication and to see the evaluation of treatment response. So available tumor markers are the serum alpha fetoprotein, beta HCG, and LDH. So up to 90% of the non-seminiferous germ cell tumors will have elevated alpha fetoprotein or beta HCG. About 39 to 40% will having increased both. But pure seminomas may have only elevated beta HCG levels at diagnosis. That is also seen in 30% of the cases. And so you have to repeat the tumor markers after orchidectomy. Usually, the half-life of alpha fetoprotein is about 5 to 7 days, and beta HCG about 1 to 3 days. So, and the other newer tumor markers are also available, the microRNAs. So the next one is a HCG, and it comes from the sensitive trophoblast, and it is always elevated in choriocarcinomas and 50% of the embryonal carcinomas, and 5 to 10% of the pure seminomas will show elevation of the HCG. So normal value is less than nanograms in a level male. So half-life, as I mentioned, is it's about 24 to 48 hours. So next one is the alpha fetoprotein. It is secreted by the yolk sac, and if there is elevated alpha fetoprotein levels, it will rule out the pure seminoma and pure choriocarcinoma. Half-life is about 5 to 7 days. This LDH is a marker of the tumor bulk, and it will be elevated in tumor. When there's a high tumor bulk and the tumor necrosis is there, then LDH will be elevated. So it is used to monitor the advanced seminomas. So bit of details about seminoma. 85% of the pure classic seminomas, and there's no specific tumor marker. So as I mentioned, LDH is used to assess the tumor bulk. 50% of them are some having sensitive trophoblastic components, therefore beta HCG levels will be elevated. So they are less aggressive than non-seminiferous germ cell tumors, and they might present in early stage, that is stage 1 disease. So there's no poor risk category for seminomas, and they're highly radiosensitive and highly chemosensitive as well. So there are special type of seminomas, the anaplastic one. Out of the 10% of the seminomas are anaplastic, and they are the leading, they are the cause, 30% of cause for the death in seminoma. And they might present in delayed stage. So, and there's spermatocytic lymph seminoma, 1 to 2% of them of the seminomas are spermatocytic, and they are having a good prognosis out of the all testicular tumors. So then non-seminiferous germ cell tumors, usually, as I mentioned, yolk sac tumors, teratomas, they comes under non-seminiferous germ cell tumors. So they might present at young age compared to the seminomas, more aggressive than seminomas, because 2/3 of the present with stage 2, that is nodal disease. and they are also highly chemosensitive, even curative in stage 4. So surgery sensitive tumors, they are surgery sensitive, so there's a place for retroperitoneal lymph node dissection for these non-seminiferous germ cell tumors. But there's no role for radiotherapy in non-seminiferous germ cell tumors. So other tumors are the Leydig tumors and Sertoli cell tumors. So this is the TNM staging system. The specific thing is we have included the T stage, nodal state, metastasis, and the serum tumor markers also in the staging system. So this is again the American Joint Committee Cancer Stage TNM staging system. So stage 1 is tumors localized to the testis. Stage 2 is the nodal disease. 2 again divided into A, B, and C. A is the lymph node masses less than 2 centimeters. B is 2 to 5 centimeters, and C is lymph node masses more than 3 centimeters. And there's Royal Marsden classification is also staging system also, which is similar to this TNM staging system. So let's see the initial management of these testicular tumors. So first thing is the inguinal exploration, and the orchidectomy is the treatment of choice. And there's a place for testis sparing surgery in bilateral synchronous tumors or in tumors in solitary testis. So in this testing setting, at least 2 additional testicular biopsies has to be taken to exclude germ cell neoplasia in situ. So this is all we know about how to perform a radical inguinal orchidectomy. You go for with the inguinal approach, and you get the control of the cord at the deep ring, and you clamp it, and then remove the cord and the spermatic cord and the testis with its coverings to prevent lymph seeds. So before going with the orchidectomy, we have to discuss with the patient regarding the testicular prosthesis as well as the sperm banking. So the complications of prosthesis insertions are the excursion from the scrotum, contraction and migration, chronic pain, hematoma, and infection. So if you are planning for immediate chemotherapy, as in nodal disease, so if the patient is having a risk of infection, so you have to balance the risk as well. So it might delay the starting of the chemotherapy. So what is the place for contralateral testis biopsy in testicular cancers? The purpose of this contralateral testis biopsy is to rule out the germ cell neoplasia in situ in the contralateral testis. The risk is about 5 to 9%. So if they are saying contralateral site germ cell intraepithelial neoplasia, there's a 50% risk of developing testicular tumors in next 5 years. So EU recommends to do contralateral testis biopsy if the patient is less than 40 years with the contralateral testis volume less than 12 millimeters. So because it will increase the risk of developing germ cell intraepithelial neoplasia by 3.78%. So, and it should be also considered in men with history of undescended testis and subfertility, poor spermatogenesis, as they are associated with germ cell neoplasia in situ. And this contralateral biopsy is not indicated with patients more than 40 years without risk factors. So the disease management, seminoma, clinical stage 1. Stage 1 is a localized disease, and roughly about 70 to 80% of them are cured with the inguinal orchidectomy. But at the time of orchidectomy, 20% of the time there will be subclinical metastasis in the retroperitoneum. So they might trigger later on life. So in seminoma stage 1 also, there's a place for adjuvant treatment, either chemotherapy or radiotherapy. That has to be decided with the discussion with the patient, incorporating the patient risk and the benefit, as well as the individual patient circumstances. So survival is, if the disease in the stage 1, it's almost 100%. So the stage 2 disease, that is the lymph nodal disease. So if the patient present with the stage 2 disease in seminoma, the preferred treatment is the chemotherapy. And if there's a contraindication, you can go ahead with the radiotherapy as well. So 2A disease means a very large 2 to 5 lymph node mass. Again, the preferred one is a chemotherapy. And if there's an alternative, we can go for radiotherapy because seminomas are radio sensitive. And the place for the PET CT scan in seminoma. So it is a useful investigation to separate the confirm the residual tumor mass in active tumor mass in retroperitoneal lymph node masses. Usually, it is recommended if the tumor mass is more than 3 centimeters that do not regress after therapy. So if there's a positive PET scan after 4 to 6 weeks of chemotherapy, it is a good predictor of active disease in the retroperitoneum. So the follow-up of seminoma stage 1 patients, you have to follow up with the clinical examination, tumor markers, as well as a CT scan, the abdomen and pelvis and chest. So you have to, first year, 2 times, and second year again 2 times. You have to see with the tumor markers as well as the contrast CT, abdomen and pelvis. Then non-seminous germ cell tumors, clinical
You
stage
will have
1.
another 5 minutes.
Okay. Yeah. Then management is again inguinal lockedectomy. And after that, there's place for surveillance or either chemotherapy or retroperitoneal lymph node dissection. But 70% of the non-seminous germ cell tumors are cured with inguinal lockedectomy alone. But there's a risk of 30% risk of relapse. But that is also again 80% of them occur in first year of life. So we have to balance the risk again and to decide on adjuvant therapy in stage 1. So the EU recommendation is we have assessed the risk, and then if the patient is having low risk disease, again low risk and high risk disease is there depending on the vascular invasion. And if the vascular invasion is there, we consider it at high risk and we offer him adjuvant therapy. Adjuvant options are the chemotherapy, and if the patient is not suitable for chemotherapy or not willing, then option is retroperitoneal lymph node dissection. So again, low risk disease, standard option is the surveillance. And if the patient is not willing or not, there are contraindications for surveillance, then you can go for chemotherapy. So as I mentioned in the previous slide, vascular invasion is the most important prognostic factor in non-seminomatous germ cell tumors. So if there's vascular invasion, there's a 48% risk of developing metastatic disease. So if it is there, we go for adjuvant therapy. Again, follow-up, it will depend on the adjuvant treatment that we select. If you are following up patient with the surveillance, we frequently get down the patient with 3 monthly clinic visits and with tumor markers and 6 monthly chest X-rays and pelvic CTs. So stage 2 disease, there is a lymph node disease. So we start with the induction chemotherapy, and following KISS chemotherapy, 4 to 6 weeks time, we repeat the CT scan again. And if there's a regression of the disease, we follow them up. But if the patient is having persistent lymph node disease following chemotherapy, then we look for the tumor markers. Persistent disease with stable tumor markers, we go for retroperitoneal lymph node dissection. And with rising tumor markers, we have to consider salvage chemotherapy. So unlike in seminoma, stage 2 disease, there's no place for PET scan. Bit of detail about retroperitoneal lymph node dissection, having a mortality about 1%, morbidity about 5 to 25%. So there are a lot of complications associated with retroperitoneal lymph node dissection. Chylous ascites, renovascular injuries, small bowel obstruction, spinal cord ischemia, and etc. So thank you very much.
Thank you very much for your presentation, Dr. Donita. So I would like to invite Dr. Nishantli and Patiran to conduct on this discussion as well as question and answer session.
All right. Thank you, Donita. That was a comprehensive review. I think there are a few things. I don't know how the Uromet is done these days, but I think it's going to be more intuitive if we have a small discussion about a couple of things. You know, that testicular cancer is a subject or a topic which is not very close to us as a Sri Lankan urologist and urology trainees, because the numbers are small, because of course it's a disease of mostly in the Caucasian countries. Caucasian origin of people, but it's good to have some sort of basic sort of knowledge platform where you can build up several things on top of that. Right. So if we ask about a couple of questions, then just to clarify some doubts as well as to give some input. So if you look at the age of patients who are presenting with testicular cancer, if somebody asks you, so let's cover both the MCQ part and the Viva, sometimes they can ask you. So if somebody asks you about what do you know about the age of the testicular cancer presentation, and can you give us more elaborative answer for that? What do you think?
So basically, there are two peak incidents for the testicular cancers. Again, for the seminomatous germ cell tumors and the non-seminomatous germ cell tumors, the peak incidence for the seminomatous germ cell tumors are it's in the fourth decade, that is 30 to 40 range of age. And for the non-seminomatous germ cell tumors, they present fairly early, in 20 to 30 years. It's in the third decade. And these non-seminomatous tumors also present in pediatric age group as well. And
Yeah, I think that age breakdown is good enough. And the other thing is, if anybody comes above 60 years of age, what are the other thoughts of testicular mass? Is it usually the age? Usually it's
yeah, not
the
usual age, but
yeah, the median age is around, as you said, it's third decade, isn't it? 33,
yeah.
35, that's the age. But if somebody comes above 60, one of the considerations is whether it's a lymphoma. And and also, do you know any other testicular masses which can present other than the uh, testicular tumor or pure seminoma and non-seminoma, as well as you said that the stromal tumors. Other than that, we discussed about the lymphoma. What else can present as testicular masses?
Certain benign conditions like chronic ongoing infections with tuberculosis, and those things will present with
Yeah.
testicular masses sometimes.
Yeah, of course. Yeah. So benign masses like even syphilis can present with a gamma in the testes. And also, as you said, as somebody has answered in the chat, um, the sarcomas, liposarcomas and rhabdomyosarcomas, all the components can give rise to sarcoma. So they can present as that. So that's something important. So the age of presentation, and I just wanted to touch upon about the risk factors. You said that the cryptorchidism is a risk factor. Can you give
Yes.
some numbers?
According to that evidence, it's the risk is from 40 to range from 40 to 13%, depending on there's
Yeah, how I
cryptocurrency.
remember this is like you just need to have some random numbers or something which is memorable. Otherwise, it's not practical enough to keep it in your long-term memory. So how I remember is like 1.5, 3, and 6. So for example, if somebody is having cryptorchidism on one testis, to have a testicular cancer on the contralateral, risk is around 1.5-fold. And if somebody is having cryptorchidism, so to have the testicular cancer on the same side, if he has had corrective surgery or orchidopexy before the what do you call the teenage age, usually what they consider is age 13. So if it is below 13 years of age, if they had the corrective surgery, the risk is around 3%. And if somebody has had cryptorchidism and he hasn't had any surgery, or if he has had any surgery after 13 years, the risk is around sixfold. So usually 1.5, 3, and 6. So that's something which you can remember. And of course, you said that having a risk of testicular cancer when you have cancer on the other side is around 5%. So that's those are other important numbers which you need to remember in testicular cancer.
The other thing is you
Yes,
find this history of cryptorganism in 10% of patients who come up with testicular cancers. So that is again a good to know number, apart from what you mentioned. If you take everyone who comes with a testicular cancer, out of them, there will be a history of testicular cancer is in 10% of them.
Yeah, exactly.
These are all fancy numbers for MCQs, as
Yeah, of course.
Nishant
Yeah.
very correctly mentioned.
Yeah, of course. These are numbers which it's very interesting to know some of the numbers which goes with some common denominator, so you can easily remember, right? 1.536, and then make some sense out of them. Right. The other important thing which I think that you discussed about the clinical presentation. Do you know any acute clinical presentations of testicular cancer?
Stage 2 disease or stage 3 disease, widespread lymph node metastasis might present with acute presentation with lymph node and respiratory. Yeah.
What causes the acute presentation?
Tumor necrosis.
What is the acute presentation that you know?
They might present with widespread pulmonary metastasis with respiratory difficulty. And
yeah, of course, yes. They can present with hemoptysis and difficulty in breathing with widespread bulky lung metastasis. Any other thing which can present with some acute medical issues?
Because of the retroperitoneal lymph node involvement, there will be lower limb venous congestion, and they might present with thrombosis of the lower limb.
Yeah, and of course they can present with bilateral obstruction of the kidney if the disease is advanced. So that's something which can present as in an advanced disease. And of course, we know that these tumors can be non-testicular in origin, so they can occur as a primary extratesticular gonadal tumors in the retroperitoneum and in the mediastinum. So that's the other thing. The other important thing is one of the other funnily behaving tumor is choriocarcinoma. So they can come with brain metastasis and very widespread, because how does the choriocarcinoma spread? Yeah, it's
hematogeneously rather than
yes, very good, very good. So it's predominantly hematogenous, so they can present with brain mets, lung mets. Anything else when you talk about the choriocarcinoma? Any interesting facts? I think you mentioned that because the choriocarcinoma is usually a non-seminamatous germ cell tumor, but you can predominantly see they don't secrete AFP, they secrete beta-HCG.
Yes.
So that's the other thing. And any numbers that you could suspect choriocarcinoma if you see a tumor marker, any cutoff values? So usually if the beta-HCG is, usually they come with very high levels. So if it is especially advanced disease, so if somebody comes with beta-HCG of more than 50,000, you had to straight away suspect choriocarcinoma, and then they are the type of people who you mentioned about the staging investigation. So yeah, those are the type of people who will straight away need I mean, rather than the conventional staging of chest abdo-pelvis, they will need an MRI brain, because that can sort of come with brain metastasis. And the other acute presentation that can happen is a thing called a chorio syndrome. Have you heard of choriocarcinoma syndrome or something like that? No? These are not very important. They can appear in your MCQs, right? So the beta-HCG can cross-react with the LH and TSH receptors. They can sometimes cause thyrotoxicosis-like symptoms. And the other important thing is the choriocarcinoma syndrome is usually seen when somebody comes after single dose of chemotherapy to widespread metastasis. So they can come with hemorrhagic metastatic deposits. So they can come with subdural or brain hemorrhage. So these choriocarcinoma mets tend to undergo hemorrhagic necrosis after chemotherapy. So that can appear in an MCQ, one of the things which can appear. And other thing, which I just hand over Supun, just before handover, I'll just, you mentioned about the tumor markers, right? So when you talk about tumor markers, if somebody asks you how tumor markers, what is the role of tumor markers in testicular cancer in a broad question, how would you answer that?
Tumor markers are important in testicular cancers for the diagnosis and
Yeah,
staging
give us an
purpose.
example of how it's important in diagnosis.
Yeah, the common tumor markers are beta-HCG, alpha-beta protein, and the LDH. So
Yeah.
in 90% of the non-seminal germ cell tumors will be having elevated alpha-beta protein or beta-HCG. If it's a pure seminoma, there won't be elevation of alpha-beta protein. And about 30% of the time, in seminomas, there will be elevated beta-HCG.
Right. In an MDT, in a cancer MDT, you present a case, and the histopathologists say, right, this is a pure seminoma in the testis after radical inguinal orchidectomy. But then you find that his AFP is slightly elevated above the normal range. What are your thoughts?
Could be mixed tumor, sir.
Yeah, it's there are a couple of things, right? So the alpha-beta protein can be elevated in benign conditions. That's another MCQ, because chronic liver cell disease and any pancreatic or any other bowel malignancy, alpha-beta proteins that can go up. Any other recreational medication? Marijuana. So of course, slight increase, not a huge increase. But if there's a significant increase, you have to know almost always this is not a case of seminoma, even though you see it in the testis, that is 100% a pure seminoma, but there may be other parts of the disease, maybe in the retroperitoneum, there may be concurrent non-seminimatous component. So you treat the patient as a non-seminimatous germ cell tumor rather than a seminoma. So that's how it's important in diagnosis. So the second thing is, of course, what is the second?
Staging.
Very good. So it's a part of a stage. So a serum tumor marker stage. And what is the third important thing?
So then again, for the assessment of treatment response.
Yeah. So treatment response and prognosis, isn't it?
Prognosis.
Yeah. So if somebody's got very high tumor markers, it's coming down after operation, is a good response of the bulk of the disease. If it is not coming down, we'll have to think that there's a significant metastatic disease with the patient. And the third important thing, what is the last important thing? It's a tool for surveillance, isn't it? So you can use, if it is a secreting tumor, you can use for surveillance. So those are the summary that you need to remember about the markers. And of course, there are many other things. These markers are very important in MCQs. So they can appear, so we just discussed the very high levels of beta-HCG. And the other important, one of the common MCQ kind of a thing is that the choriocarcinomas, the yolk sac tumor and the embryonal tumors. So if we get embryonal tumors, as far as I remember, they present very high levels of alpha-beta proteins, but yolk sac tumors, they come with slightly less. So that's another thing which can come. And of course, we discussed about the other non-malignant elevation of these tumor markers. So LDH is again a bit of a non-specific marker. We use LDH1 as a isomer. So there are so many isomers, so we use LDH1 for testicular cancer. Basically, sometimes it can assess the response of a bulky tumor. So that's one of the places. Yeah. So Supun, any more things to add about the?
Yeah, Dunita, I have two questions basically. Now you are in your clinic, you diagnose the testicular cancer and you're consenting the patient, and you wanted to consent the patient for sperm banking. But the patient was not very keen on that. He's a young chap, say 25 years old, not married. But he's not convinced about the requirement of sperm banking. What would you tell the patient? Why is it so important to consent these guys for sperm banking? Why do you think so?
So with the orchidectomy, again, the hormone levels and the testosterone level will go down compared to the normal patient, as well as with the adjuvant treatment, the chemotherapy, patient may not be able to have a have a baby in the future. So therefore, I will convince the patient that because of the adjuvant treatments, even though now the patient is not may not be having a metastatic disease, but if the patient might require chemotherapy in the upcoming years, so therefore there's a place for sperm banking for this patient.
Good. That's a very good point. But the patient says that I will have one testicle left. So now he's aware that one testicle is good enough for fertility. What would you tell the patient now? He's arguing with you.
Yeah, I say that, yeah, that is true, but with removing one testicle will reduce the hormone levels as well as the chance of having the paternity. So that is
okay.
why
So
we need to
yeah, you mentioned one very strong point for sperm banking, that is the adjuvant chemo. Adjuvant chemo brings down the sperm counts and the quality of the sperms very, very low. That's correct. But what you need to mention here is that when you have a testicular cancer on one side, what is the chance of having abnormal sperm counts and abnormal seminal analysis? What is the chance of having an abnormal seminal analysis in a young man being recently diagnosed with testicular cancer? I don't want a figure because there is no figure available, but you need to know is that their sperm counts are more than likely to be abnormal. Yeah.
Yeah, especially in a non-seminomatous germ cell tumors.
That's right. So you get them in the young patients, isn't it? So seminomas you see in the elderly population, not really elderly, I would say middle age. So we are talking about young people, and you're talking about non-seminomatous germ cell tumors. So you need to bring out the fact about the testicular dysgenesis syndrome. Are you aware about it? Or did you talk about that in your presentation? Because
No, sir,
I joined
no.
in halfway of in your presentation. Did you talk about it?
No, sir.
Well, I think
so. What do you know about testicular dysgenesis syndrome?
No, sir. I'm sorry, I'm not aware of that.
So read about it. It's something that you need to know. Now, it's interesting. We think that all this, say, undescended testes, testicular tumors, say bell clapper testis, and abnormal sperm counts and everything happens due to an integral problem in the genesis of the testicle. So, and because of this genetic abnormality, you run a high risk of having testicular cancer. So when you have a testicular cancer diagnosis, it's not only the testicular cancer that you diagnose, it's the testicular dysgenesis syndrome. Oh, this testicular tumor is one part of it. And together with that diagnosis, you come up with, say, low quality sperm analysis, and then the testosterone levels and lots of other problems with the contralateral testis. So it's not purely isolated malignancy that you diagnose when you, especially with young people diagnosed with non-seminomatous germ cell tumors. That's what you need to understand. If you do a seminal fluid analysis for these guys, you will see that there are lots of abnormalities, azoospermia, say, lots of other things. Yeah. So that is one thing that you need to tell these patients. Although they will have one normal testis, that seminal fluid analysis is not going to be normal most of the time. Yeah, so if the patient is not convinced, you can offer them a seminal fluid analysis and see where we stand. That is the most important bit. And then the adjuvant chemo. Yes, that is the other point that you need to mention when you counsel a patient for sperm banking. It's nice to know how it is run in Sri Lanka, but I haven't come across this problem when I was there, and I don't know how it is run now, whether it is entirely private or whether there is any, say, government funding or something for the sperm banking business. I'm not sure, but it's nice to know how it is run in Sri Lanka as well. Yeah.
Yeah, I think
Dunitha?
the other thing, Supun, I think about the after completion of these chemotherapy, the general consensus is to avoid pregnancy because of the high risk of, the sperm mutations and all these things. So I think you need to have
one more reason for sperm banking.
Exactly. So, so that is another concern that you need to give, that they usually have to undergo genetic counseling about the chance of having mutations and all sort of problems. That's great, and I think
Nishant, I have one more question. Is that
Sure.
okay?
No, go, because I think
Who is moderating?
majority of the discussion would be around this section. So
That's
we'll
right,
be
yeah.
spending more time on this, because there's no point talking hi-fi stuff about the chemotherapy regimes and things, because these things are mostly in the hands of oncologists, but this initial bit of management is
Yeah.
very important. Yeah, carry on.
Do I have permission? Who is moderating?
Yeah,
We are
Dr. Supun, you can.
Okay.
Chaminda is moderating.
Okay. Okay, right. Okay, so Dunitha, I'm sorry I have to ask the question from you. So now you convince the patient to do contralateral biopsy. Now we've evaluated the risk factors. Now you made the decision that you need contralateral biopsy. How do you do that?
So contralateral biopsies can be done either open approach with a scrotal incision, or it can be done with the core-cut biopsy needle as well. So either techniques, we can yield a sufficient amount of testicular tissues for the analysis.
What would you do? So what is the problem now? Now you're doing an inguinal orchidectomy for the tumor side, and you have to make a separate incision for the biopsy on the other side, isn't it? If you're doing open biopsy, yeah?
Yes.
So that is the problem, I mean, you have to, if you can do both operations with one incision, that's all right, but you will have to make a separate incision on the other. Have you done it ever?
Contralateral biopsies we have not done.
No, okay, so most of the time it's an open biopsy. We don't use the true-cut biopsies for that. So we do an inguinal orchidectomy for the tumor side and make a scrotal incision on the other side, and then do an open biopsy. In the same note, what are the different approaches for radical orchidectomy? How do you do radical orchidectomy? How do you do radical orchidectomy?
So we used to do with the inguinal incision. We open into the inguinal canal, and we identify the deep ring and get the control at the deep ring initially, and then only you dissect the cord and the testis out of the scrotum with the coverings, and then you divide and remove the testis and the cords.
Okay, so what are the practical problems you can come across in this approach? I mean, if it is a large tumor.
There will not be possible to deliver from the inguinal incision sometimes, because
what would you do then?
Might have to extend the incision. We have to divide the superficial ring, and then
most likely you don't have to extend the skin incision. You might have to cut the superficial ring, isn't it?
ring. Yeah.
Yeah. So have you heard about subinguinal radical orchidectomy?
Sure, sir.
Okay, so it's a popular approach here, and I think there is a good amount of literature for subinguinal orchidectomy. The idea being you don't have to open the inguinal canal and the risk of hernia and everything. But I mean, to be honest, it takes about half of the time that is taken for an inguinal orchidectomy, because you don't go near the inguinal canal. You deliver the cord at the superficial ring, clamp the cord, and do everything similar to an inguinal orchidectomy, and you don't have to close the inguinal canal. There are good amount of literature behind this. The only difference is the length of the spermatic cord is a bit shorter than the uh, inguinal orchidectomy, but it was found to be non-inferior, and there is no outcome differences between the inguinal and subinguinal orchidectomy. So it's something that we don't normally do in Sri Lanka, but it's a good thing to know. And it is, when you do it, you love it, because it's very quick. I mean, you just make a horizontal incision just above the superficial ring, about 2 to 3 centimeters, and the job is done in 10 minutes. And everyone else in the theater will love it.
Yeah, super. Now, for the, I mean, the interest of sake, could we just ask the audience that what is why people are not doing subinguinal and why people are doing inguinal? What's the theory behind this? Dunita knows?
As the Dr. mentioned, the length of the cord, remaining length of the cord will be there in the inguinal canal. That may be the reason.
Well, you can extend it if you need a little bit more. So I think the primary concern is the lymphatic drainage, isn't it? Yeah, somebody wanted to tell something, yeah?
Yeah, same thing, sir. But the lymphatics, the drainage pathway, it goes along the spermatic cord. So we
That's
have to
right.
go, if we go up to the
That's
deep
right.
inguinal ring, we get
Yeah.
the onco clearance is much better.
Yeah, so you're going to reroute the lymphatics if you start opening it through the scrotum. Remember, Supun mentioned this is a subinguinal, not a scrotal incision, right? So if you do a scrotal incision, there is a risk of that you're rerouting the lymphatics through a contamination to a different node. So there will be inguinal nodes, and you won't be able to achieve any cure if that's the case, because you can't give a particular radiotherapy, you can't give a retroperitoneal lymph node dissection. So that is the concern, but this subinguinal approach is getting quite popular here. So in the long run, as Supun says, we're practicing evidence-based. So there's no significant evidence to say it goes other way around. So that is why it's an approach which is getting popularized. So what you need to know is why you're not doing that. So why you're not doing a scrotal exploration. So that's the answer for that. Yeah, go ahead, Supun.
Yeah, I think that's about it. I mean, I think because we have more presentations, we can pick up more questions along the way, isn't it?
Yeah, absolutely. Yeah. So anybody has any questions? I think just to clarify about the adjuvant, I agree most of the stage 1 seminoma. So the most important thing is stage 1 seminoma. If it is confined to the testes, it's almost 100% curable by doing an orchidectomy. But the most important thing is what you need to know, the number of people who will recurrence after only providing orchidectomy. So that percentage can come in your MCQ, around about 15% can recur. So the highest risk of recurrence is first 2 years. And then the up to about 5 years, that risk is there. But then after 5 years, you have to talk about the survivorship and sort of your screening or your surveillance does not stop there. So you need to have some arrangement to continue the surveillance. So it's very important to have this discussion up front with the patient. So after the whatever the orchidectomy, you can be offered surveillance if the patient is quite a reliable patient. Also, you can be offered a chemotherapy or a radiotherapy, which is not very commonly done, but single dose chemotherapy is the other very good option for stage 1 seminoma if the patient is not reliable on surveillance. But then this has to be discussed with the patient. You should not overtreat them, because if it is a very tiny tumor, in the test is with no risk factors. I think, yeah, some people in some textbooks, the tumor size more than 5 centimeters and a retitestis involvement is considered as a high risk factors. So that sort of, if these factors are not there, very tiny isolated testicular tumor, then of course in the MDT discussion, you need to have a good balance between a risk versus, benefit of over treating. So surveillance is a good strategy there. But then again, if it is not very reasonable, you can go for a single dose treatment. But it's different in the non-seminimeters. There's a clear risk factor profile. So yeah, I agree with that. Yeah, Chaminda, we can take the next, isn't it?
Okay, thank you, our expert panel, for this valuable information. So we'll move to our next topic, that is metastatic seminomatous testicular cancer. Going to present by Dr. Shehan Ratnayake, is a senior registrar from Columbus Teaching Hospital. Over to you, Dr. Shehan.
Very good evening to all of you. I hope you can see my presentation. I will be discussing about metastatic seminomatous testicular tumors. The first few slides will be a repetition of what Dr. Vinitha told, and as Nishant sir told, it will be an oncology-heavy presentation. So before going into the specifics of seminomatous tumors, regarding the treatment of metastatic germ cell tumors, there are a few things that we consider when deciding on treatment. One is the histology of the primary tumor. And the second is the prognostic group as defined by the International Germ Cell Cancer Collaborative Group, as well as the tumor marker decline after the end of the first cycle of chemotherapy, especially in the poor prognostic group. Again, this is the staging system which we already have discussed. And when it comes to metastatic tumors, everybody who has clinical metastatic disease are included in stage 3. At the same time, without evidence of obvious metastasis, very high tumor marker levels are also included in the same category. This is the International Germ Cell Cancer Collaborative Group staging system. It represents seminomatous tumors in the good and the intermediate prognostic group. The difference is that the intermediate group has non-pulmonary visceral metastasis. I'll talk a bit about the clinical stage 1 disease patients who have persistently elevated tumor markers even after orchidectomy. In these patients, if we have not already done, we have to reconfirm that there's no contralateral testicular tumor, after which we can monitor them, their tumor marker levels. And if there's an unequivocal rise in tumor marker levels, they should be treated as good prognostic category metastatic tumors. And patients who have stable tumor markers, they should undergo restaging after 4 to 6 weeks. And if they are stable, they can continue to be under surveillance. When it comes to stage 2A and 2B disease, Dr. Dunitha has already discussed about this, but a little more detail about this is that chemotherapy will result in overall survival of more than 99% and very few relapses. So that is actually the preferred treatment of choice, though radiotherapy is having equal efficacy, though there are no randomized control trials. But a meta-analysis has shown that it is there's a trend towards a better efficacy of chemotherapy, especially in stage 2B disease. This is a treatment schedule which was already discussed. And in patients who have enlarged retroperitoneal lymph nodes which are less than 2, which is node 1 category, having normal tumor marker levels, they should not be started on chemotherapy straight away. They're generally monitored for another 6 to 8 weeks time. And the metastatic disease can be confirmed by either rising tumor markers or the size of the nodes, or else a biopsy can further help come to a diagnosis of metastatic disease before starting treatment. The stage 2C and 3, the metastatic category, as I told, has been categorized into 2 parts, the good prognostic group and the intermediate prognostic group. They're primarily treated with chemotherapy, and the regimes include what is known as BEP, or bleomycin, epirubicin, and cisplatin. So they are given in 21-day cycles. 3 are given for the good prognostic group, and 4 cycles are given for the intermediate group. Whoever who has contraindications for bleomycin in the good prognostic group can be given only EP, and the intermediate group will receive VIP, which include etoposide, cisplatin, and ifosfamide. Few special circumstances. One is a patient who's having a poor performance status, or patients who have extensive liver metastasis. They will be started on a reduced dose therapy regime to reduce the acute morbidity and mortality of chemotherapy and tumor lysis. And if they have widespread pulmonary metastasis, again, a dose reduction with only EP is used, excluding bleomycin, to reduce the chances of pulmonary hemorrhage and ARDS. And in men who have germ cell cancers, in general, have a higher risk of venous thromboembolism. So we can consider giving venous thromboprophylaxis for these patients, but patients like those who have choriocarcinomas, as Nishant said, has a higher risk of bleeding, so they should not be given venous thromboembolism prophylaxis. Following treatment, after initiation of the induction cycle of chemotherapy, that is the first cycle of chemotherapy, we should look at the response of these patients with imaging as well as tumor markers. So if they are showing regression in the tumor marker level, then we should continue and complete the planned chemotherapy regime. And if there's a decline in the markers but progression of tumor in the imaging, still we would be completing the induction therapy. And in patients who has a slow decline in tumor markers, adjustment in dose and dose intensification is considered. After completion of the first-line chemotherapy, the normal tumor marker levels and residual tumors less than 2 centimeters, these patients can undergo surveillance. And patients who have tumor size more than 3 centimeter residual tumor with a normal tumor marker level, this is a contentious area where we are not sure whether the patient has residual disease. So there's a place for doing FDG PET in these patients, and it has a very good negative predictive value. So if there's no significant uptake, you can be, it's more than 90%. So you can confidently say that the patient does not need any further therapy. But if it is positive, still the chances are that there might be a residual disease. So still you repeat in another 6 weeks time and see the progression. And at a point where you have unequivocal evidence that there's metastatic disease, you would offer salvage therapy. In patients who have high or progressing beta HCG level after finishing chemotherapy should receive salvage chemotherapy. And progression of tumors without beta HCG progression will need histological verification before offering salvage chemotherapy. And in at any point, if retroperitoneal lymph node dissection is considered in seminomas, it should be done at a referral center, because there will be intense fibrosis in the retroperitoneum, which will make the surgery a very difficult one. The systemic salvage treatment for relapse as well as refractory disease, again, it's cisplatin combination therapy that we are giving. That includes 4 cycles of 3-agent regimes, which include cisplatin and ifosfamide, but in addition, it might be etoposide, paclitaxel, or gemcitabine. These regimes are having a higher hematological toxicity, so they can be given prophylactic with GCSF. There are prognostic models to look at the relapse rate and survival after salvage chemotherapy following the relapse or refractory disease. So they are looking at the primary tumor, the response, the progression-free interval from the first completion of the first chemotherapy, and the tumor marker levels, as well as liver, brain, and bone metastasis. And looking at that, they will give 2-year and 3-year survival. Regarding follow-up of patients with metastatic germ cell tumors, seminomatous tumors, so they should have, they'll be given follow-up with tumor marker levels, chest X-ray, and abdominal CT. In the place of CT, MRI can be used, but both are equal in efficacy. In patients who already have pulmonary metastasis, they should be under surveillance with CT thorax. So initially, it's a more intense surveillance during the first 2 years, because that's the time they get most of the relapses. So 3 monthly tumor markers and 6 monthly CTs, but later on at 3rd, 4th, and 5th year, it's relaxed as it goes on. Regarding the imaging, as I already told, the CT and MRI have comparable sensitivity. We are primarily looking at the size of the residual or recurrent disease, but other features like necrosis and irregular shape are also considered. There's no routine role for PET-CT apart from the already discussed scenario where the patient has tumor of more than 2 centimeters with normal tumor marker levels. And there's no routine place to do scrotal ultrasound to assess the contralateral testis. Place of tumor markers, that's the least invasive of the investigation. So we are doing tumor markers regularly to detect relapse of the disease. And it can detect microscopic disease as well, even when the imaging is negative, but there can be false positives as well. So because of that, it's always, we have to look at the serial values and see the trend or confirm it with imaging. Few terminology, late relapses are the patients who have relapses after 2 years of completing the chemotherapy. It can occur in about 1.4% of patients with seminomatous tumors. And very late recurrences are those recurrences which occur after 5 years, but that's a very rare event, only occurring in about 0.5% of the tumors. So routine surveillance to detect recurrences are not done beyond 5 years, but after 5 years, it's mainly the cancer survivorship that we are concerned about. So the treatment-related toxicity should also be looked at during this initial period as well as after 5 years. So late toxicities of chemotherapeutic agents such as bleomycin can be pulmonary toxicity, and cisplatin can give rise to neuropathy, ototoxicity, and cardiovascular risk is increased in these patients. And ifosfamide and cisplatin can cause nephrotoxicity. And second malignancy can occur especially with RT during in the field of irradiation. And the chemotherapeutic agents such as cisplatin can give rise to leukemias. And regarding their fertility, we have already discussed about the issues of fertility. So these things should be addressed during the follow-up period. So that brings me to the end of the presentation, and I think we can discuss afterwards. Thank you.
Thank you, Dr. Shehan, for your excellent presentation. So I would like to ask Dr. Nishanta whether we go for the next presentation or we are going to conduct the discussion at this point.
Well, I think we discussed the board, isn't it, Supun?
At the end, yeah.
Yeah. And then if you can, then we can talk some
Uh,
more.
I'm not sure whether the next speaker is going to talk about the prognosis, is it?
I think it's
No, seminomas.
the advanced
Seminoma.
non-seminomatous, is it?
Yes. So
Yeah,
the
I'm the next speaker. My topic will be on non-seminomatous tumors. Mostly, although I was given a metastatic disease, I will be touching the locally advanced disease as well.
Okay.
Okay, one quick question to Shehan. Shehan, where is IGCCG classification?
So I will be discussing that as well.
Are you going to discuss it? Is it?
Yeah. I'm
Okay,
going to
no
discuss.
problem. All
Yes.
right. My apologies. Sorry. Carry on, please.
I'm going to talk about metastatic non-seminomatous stem cell tumor. As this was already, there will be some repetitions. So according to the staging, as we know, we have TNM plus tumor markers. Here, N1 less than 2 centimeter, lymph nodes N2 2 to 5 centimeter, N3 more than 5 centimeter. Then coming to these tumor markers, depending on the level of tumor markers, then we have categories of S1, S2, and S3. For the management purpose, we have to know the stages. There are different stages: stage 1, stage 2, and stage 3. So basically, in metastatic non-seminomatous stem cell tumor management, stage 3 disease, that is the metastatic disease, as well as stage 2C also included in the management for the management category. So as we know, the risk factors for occult metastasis depends on the histological type, and as well as there are some poor risk factors such as in seminoma, it is about the size and the involvement of the reted testes. In non-seminoma, mainly it's a lumbovascular invasion. How can we stage? Local staging is done by the ultrasound scan or MRI of the scrotum and tumor markers, CECT chest and abdomen, and CECT chest, abdomen, pelvis for the to look for distant metastatic spread. So MRI is not routinely done, but it is better for the lymph node assessment. And when the need for a cerebral and spinal imaging not routinely recommended, but if we are suspecting brain metastasis, in case of even patient comes with multiple metastasis, or if the beta ICG is so more than 5,000, especially if we are suspecting choriocarcinoma, or if the patient is having clinical symptoms suggestive of cerebral or spinal metastasis, then we can go for MRI of the brain and spine. And there's something called microRNA, and that is also newly available to support the staging. So whatever the whether it's a non-metastatic or whether it's a stage 1 or stage 2 or stage 3 disease, the primary, we are starting management with the radical inguinal orchidectomy. So the primary treatment is radical inguinal orchidectomy. So after the radical inguinal orchidectomy, we had to repeat the tumor markers because tumor markers, because the TNM staging is based on post-orchidectomy tumor markers value. Usually it is repeated depending on the T-half. As we know, alpha fetoprotein takes about the T-half is about 5 to 7 days, and beta ICG about 2 to 3 days. So depending on that, usually after 2 or 4 weeks, we are repeating the tumor markers. And then after the orchidectomy, if the persistent elevated tumor markers, we have to think about whether they are a subclinical or occult metastasis. So this is already it was mentioned, the alpha fetoprotein, it can be falsely elevated in cirrhosis, hepatobiliary malignancy, or there are some liver conditions. And beta ICG, it can be falsely elevated in hypothyroidism, hypogonadism, and marijuana juice. And T-halves also here mentioned. So depending on the T-half level, we had to repeat the tumor markers after the orchidectomy. So when we are dealing with the metastatic disease, so advanced disease, we have to categorize the patient into 3 categories. This is according to the International Germ Cell Cancer Collaborative Group. There we have good risk and good risk, intermediate risk, and poor risk. So good risk categories where we have the testicular or primary with no non-pulmonary visceral metastasis, and you can see the alpha fetoprotein is less than 1000, SCG is less than 5000, LDH is less than 1.5 of the upper limit. So depending, then intermediate risk when the tumor markers are high. Then poor risk, you can see that you can compare with the seminoma, there is no any poor risk category. But in non-seminoma, there's a poor risk category, that is poor risk is when there's mediastinal primary, or when there are non-pulmonary visceral metastasis, or highly elevated tumor markers. So we have to categorize into these 3 categories. So usually we are starting with radical inguinal orchidectomy, but there are some situations where we will have to go for upfront systemic chemotherapy. Especially that, well, this is also already mentioned, especially if the patient presents with widespread pulmonary metastasis with acute presentation, then we will have to go for upfront systemic chemotherapy. So again, here, because I would like to talk about some adjuvant therapy and the management of relapse and the management of synchronous and metachronous metastasis. Here, so when even after stage 1 disease, as we discuss about stage 1 disease, you can go for surveillance or chemotherapy or retroperitoneal lymph dissection. So even after stage 1 disease, even in the stage 1 disease, even after orchidectomy, persistently elevated tumor markers, then you have to suspect whether there is any subclinical metastasis. So if there's a subclinical metastasis, again you have to restage with the CCT and repeat the tumor markers. Persistently highly elevated tumor markers, then it also comes under good category risk. So then it's an indication to go for primary chemotherapy. So T2A disease already mentioned, but I would like to say there are 2. You can go for either, there are mainly 2 options. It can be chemotherapy or retroperitoneal lymph node dissection. So when do we have these 2 options? Chemotherapy is recommended when there's a multifocal disease, and retroperitoneal lymph node dissection is recommended, especially when there's a limbovascular invasion or when there's a teratoma with the somatic malignant transformation, and retroperitoneal lymph node dissection is resected. So even in stage 2 disease also, if it is a chemotherapy, then whether it's chemotherapy or retroperitoneal lymph node dissection, there is something called adjuvant therapy. So adjuvant therapy, if you are going for a retrocranial lymph node dissection, depending on whether it's a lymph node is sometimes the retrocranial lymph node dissection histology can be positive for malignancy. Sometimes there are three possibilities. It can be a mature teratoma, or whether it can be a viable malignancy, or it can be a fibrotic or necrotic debris. So if it is a malignancy, then you have to go for further adjuvant chemotherapy. And if it is then after if the primary treatment for the stage 2 disease was chemotherapy, after chemotherapy we had to repeat the tumor markers. And if the tumor markers have come down, then you can go for adjuvant retrocranial lymph node dissection. So primarily it can be chemo or lymph node dissection. Adjuvant can be vice versa. So something about lymphatic drainage. So as we know, right side usually drains into the first into the intra-aortic cable nodes, then into the pre-aortic and pre-cable, then common iliac or external iliac. Left side first into the pre-aortic and para-aortic, then into the intra-aortic cable. So depending, because lymphatic drainage is important when we are deciding the management, especially if it is radiotherapy or retrocranial lymph node dissection. So these are called land zones. So if we are going for a radiotherapy, we are to target like a hockey stick. That means we are to cover the this para-aortic area and iliac area. So retrocranial lymph node dissection, it can be done as a conventional method or modified method. The conventional method, modified retrocranial lymph node dissection, is to preserve the retrocranial ejaculation. Here, our main target is to preserve the hypogastric places, which is situated just below the inferior mesenteric artery. So in modified retrocranial lymph node dissection, you can see the margins are right and left side. Right side between the ureter and the aorta, and upper margin is the renal vein, lower margin is we had to it's up to the origin of this inferior mesenteric artery. Left side is the vice versa. And but if it is a conventional method, we are not worried much about the preserving the hypogastric plexus. We had to go up to the bifurcation of the iliac arteries. So whatever the pre-chemotherapy, if it is a pre-chemotherapy, if it is a pre-chemotherapeutic retrocranial lymph node dissection, modified retrocranial lymph node dissection is recommended. But if it is after the chemotherapy, then we can go for a conventional method. So in conventional method, they recommend we have to follow the lumbar vessels and to ensure all lymphatic tissues are cleared, and we can ligate the lumbar vessels. And we have to make sure this all lymph nodes or lymphatics around the great vessels are cleared. So management of the stage 2B also nearly same as stage 1. Okay, you can go for a chemotherapy upfront or retrocranial lymph node dissection. Then adjuvant can be the other way. So coming to the metastatic lymph node disease, this was already discussed. There are two categories: good prognosis, intermediate prognosis, and poor prognosis. The primary treatment for good prognosis seminoma. So under the good prognosis non-seminoma, we have the patients after the persistently elevated tumor markers after the management for stage 1 disease also comes. And secondly, then we have the 2C patients also here we can include. Then the stage 3 patients. So here what they recommend is to give 3 cycles of BEP or 4 cycles of EP. So EP, there's no pleomycin. So in the pleomycin, because if there's no pleomycin, the pleomycin related adverse effect, that is the pneumonitis, is not there. That is the only advantage. But choosing whether it's PEP or PEP depends on the several factors. So duration also different. It's 9 weeks compared to 12 weeks. And also toxicity, pleomycin toxicity, we already discussed. And then what about the intermediate risk category? So in the intermediate risk category, there are 3 PEP, 4 PEP. Here the numbers are increased: 4 PEP and 4 PEP or 4 BIP. these are the both are equally recommended. And then coming to the poorest non-seminamatous tumors, here again same as intermediate, you can either go for PEP or you can go for VIP. And then after the chemotherapy, what is the management after the chemotherapy? So after the chemotherapy, again after 4 to 6 weeks of chemotherapy, we had to restage the patient with a CECT and repeat the tumor markers. So if the tumor markers, if the repeat CECT, there's no, it has resolved. So in the repeat CECT, if there's a persistent tumor, especially if there's a retroperitoneal lymph node mass with normal tumor marker, so to make the management clear, whenever we have to go for a retroperitoneal lymph node dissection or surgical approach, only when the tumor markers are normal. So whenever the tumor markers are normal, only we can go for the surgical management. Otherwise, we have to always consider whether we can go for more chemotherapy. So after the chemotherapy, you repeat the CECT and the tumor markers. If the CECT shows residual disease with normal tumor markers, then we can go for a retroperitoneal lymph node dissection. That is also retroperitoneal lymph node dissection. Here they recommend bilateral retroperitoneal lymph node dissection. Post-chemotherapy era, we are not that much very worried about preserving the hypogastric plexus. And so what after retroperitoneal lymph node dissection, again there can be viable tissue or mature teratoma or debris. If it is debris or mature teratoma, only the surveillance is enough. But if there's a viable tissue, you have to give 2 more cycles of chemotherapy. And so persistently leave the tumor markers even after the primary chemotherapy, then you have to think about whether there is a contralateralized, if there's a persistent elevated tumor markers, you have to think about whether there's a contralateral site testicular tumor or whether there's any developing metastasis. So it can be occult metastasis also, contralateral site primary disease. Then depending on the finding, the management will differ. The follow-up patient, again the same, we recommended follow-up is up to 5 to 10 years. So history, physical examination, tumor markers, and CT, annual CT is recommended. So there's something about second-line chemotherapy and third-line chemotherapy. So what is the place for second-line chemotherapy? So second-line chemotherapy is recommended in patients with disease relapse following first-line chemotherapy, or those who don't respond to first-line chemotherapy should receive second-line chemotherapy. So what is a second-line chemotherapy? As a second-line chemotherapy, we have here VIP or TIP. TIP means taxane, ifosfamide, and platinum burst. So we can go for a VIP or TIP, or we can go for if it conventional dose chemotherapy, that is a VIP or TIP, or high dose chemotherapy of previously given ones. So alternatively, you can also, if there's a resectable disease, you can also try for surgical salvage retroperitoneal lymph node dissection. The relapse can be early relapse or late relapse. So late relapse is called if the relapse is 2 years after the completion of primary therapy. They say usually the late relapse is better managed with surgical management. So early relapses are better managed with chemotherapy. Late relapse is better managed with surgical management. So something about a trial. This is an ongoing randomized international phase 3 trial. Where they compare the conventional dose chemotherapy with high dose chemotherapy. What they find is there's no, it's demonstrated superiority of the high dose chemotherapy compared to conventional dose chemotherapy. This is about second line chemotherapy. So if as we already mentioned, if there's a persistently elevated tumor markers, there's no place for PET scan. Unlike seminoma, only the PET scan is useful in seminoma, but not in non-seminoma tumor. So third line therapy also you can consider when there's a relapse. after second line therapy or not responding to the first or second line therapies, then you can consider third line therapy. Again, third line therapy is controversial. There we have conventional dose of usual drugs or conventional dose of other gemcitabine and the paclitaxel, or high dose of usual tip and VIP. Or we have, depending on the if there are MSI or MMR positive genes, then you can go for something called immunotherapy. So immunotherapy is a pembrolizumab. This is a programmed cell death binder. So you can also go for immunotherapy, and you can go for other GMOX, the combination of gemcitabine and oxaliplatin. So this is a summary of chemotherapy depending on the prognostic group. If it is a group prognosis, 3 PEPO, 4 EP. If it is intermediate, again the numbers are bit increased, 4 PEP or 4 VIP. The poor risk category, same as intermediate risk category. Something about brain metastasis. So brain metastasis is relatively rare, but almost occur exclusively in patients with non-seminoma patients. And when the indications for imaging, we already discussed, in the presence of widespread metastasis, in the presence of high beta ECG, in the presence of neurological symptoms, you can go for a imaging. And then the management, again, is a controversial topic. You can go for a cisplatin-based chemotherapy, or you can go for a stereotactic radiotherapy, or you can go for a surgical resection if it is resectable. And some interesting fact is metachronous brain metastasis is poorer than the synchronous brain metastasis. So if the patient presents you with the brain metastasis, the prognosis is not that bad as metachronous brain metastasis. And then something about other factors, the side effects factors. The side effects are already our expert panel mentioned. So because of the chemo and radiotherapy, it affects the spermatogenesis. We had to counsel the patient for sperm banking, and retroperitoneal lymph node dissection can cause retrograde ejaculation. And as already mentioned, contraception is advised at least 6 months after the radio and chemotherapy. And we had to worry about the secondary malignancies, especially with cisplatin and etoposide, both associated with the development of leukemia. And then there are acute side effects of myelosuppression is there. Then chemotherapy related gastrointestinal side effects are there. And then pleomycin can cause pneumonitis, and Raynaud's phenomenon is also reported in patients receiving chemotherapy. And cisplatin can cause renal toxicity, nephrotoxicity, neurotoxicity, and there's associated cardiovascular side effects also. And there's a risk of venous thromboembolism also already mentioned. Thank you.
Thank you,
Hello?
Devika, for your thank you, Devika, for your this more extensive presentation. So we'll go for the discussion.
Right, that's quite a lot of comprehensive data and a presentation on the advanced testicular tumor. So you discussed about retroperitoneal lymph node dissection as an option. So do you know why the right and left side is different? Do you have any idea?
Because of the, is it because of the testicular veins?
Yeah, that's the anatomical basis of the answer. So you know that the right side, the testicular vein drains straight to the IVC.
Into the IVC, and the left side are left.
Yeah, so the right side is more toward outer caval lymph nodes, and also pre-caval because of the drainage of the gonadal vein, and these are called landing sites. So the landing sites of the lymphatic drainage is more on those areas. So people have done a lymphatic mapping, so which shows right side more towards intra-aortic cable. So that's the difference. And the left side, it is intrarenal vein and mainly on the para-aortic region. So that's the two different sort of mapping that they have found out as the landing site. So because of the, in terms of reducing the comorbidities, people have found that doing a bit of a more limited dissection. So do you know what is that? Any idea about the limited dissection? Any particular wording for the limited dissection?
I don't know the names. I modified retroperitoneal lymph node dissection. I can't
Call
remember
it
the
template dissection. So they do template dissection with the
template. Yeah.
reduce sort of more restricted lymph node dissection. So they found that the outcome is similar, but then there are more newer reports that says it has a higher recurrence rates compared to the conventional. But the idea of doing a limited resection is to reduce the complications, or a template dissection, and also to preserve the nerves. You can do both the conventional and template with nerve sparing. Yeah, so the idea of the template dissection is to reduce the risk factor, the side effects of the operation. The other important thing is when you talk about the advanced disease, so if somebody comes with bulky retroperitoneal disease with a significant pelvic lymph node enlargement, what stage that patient belongs to?
So it's bulky lymph nodes, sir. I think it's 2C. If it is more than 5 centimeters, so still we had to he will come under the good prognostic category of managing metastatic lymph node dissection, provided there are no other distant metastasis.
Right, this is very important. So in testicular cancer staging, the localized disease is testis, and the lymph nodes are retroperitoneal. So pelvic lymph nodes comes under extranodal spread. So anything in the pelvis, anything above the diaphragm, they come under metastatic disease. So remember, if there's an MCQ with a retroperitoneal lymph node enlargement with some pelvic lymph node enlargement, that is extranodal disease, and that comes under stage 3 metastatic disease. Okay, so that's some important thing, because in the testicular cancer, nodes are considered retroperitoneum and retroperitoneum.
Yes.
only. Okay, fine. So that's another important thing I wanted to highlight. Then, of course, you mentioned about the ICCGN classification. So it's an exhaustive bit of data to remember, but how I usually summarize is it's easy in the seminoma group, isn't it? Pulmonary or non-pulmonary, good or intermediate. But when it comes to non-seminomatous, you have to remember what are the poor prognosis category. Okay, so if there's poor prognosis category, the data like the mediastinal primary and non-pulmonary lymph node metastases, so they are the poor prognosis. So if you have to remember them, but if you don't have any of these poor prognosis factors, if it is S1, it is good prognosis, and if you don't have these poor prognosis factors, and if it is S2, this is intermediate prognosis. So that's, you can summarize it in that way very easily. So put it on a chart, just remember, because you won't be able to remember all these things. These things can appear in your MCQs, but I don't think anybody will come and pinpoint and ask you about the whole bits and details. Then I think, yeah, anything else to add, Supun?
I think she covered most of all of it. So the the difference in management of metastatic testicular cancers lies with the approach. In certain countries where the oncologists are strong and take precedence, they give chemotherapy, like in UK. In countries where the urologists are and robotic and laparoscopic surgeons have the upper hand, they crack on and do the RPLND. So there is no real consensus about the sort of non-inferiority of either of the two options for the management of retroperitoneal lymph nodes. I think, I mean, both has its equal share of argument. RPLND is a very high morbid operation, and lots of post-operative complications which can be avoided if the tumor responds to BEP. I don't think we give the other regimes that commonly, but it's the BEP regime, isn't it? We give it for most of the NSGCTs. Seminomas, of course, matters. One thing now, after the first cycle of chemo, you mentioned that the application of PET-CT. Can you sort of touch upon about that a bit more, because it was a bit controversial about arranging PET-CT.
No, so there's no place for PET scan in non-seminomas, but it is recommended in seminomas.
That's right. So what is the specific indications to do PET-CT?
So in seminomas, after the primary chemotherapy, we repeat the after 4 to 6 weeks, we repeat this test. This one PET. If the especially in we repeat the CCT. If there are lymph node more than 3 centimeter, we have to know, because to avoid unnecessary retroperitoneal lymph node dissection, we have to know whether there is a viable tissue or whether there are no viable tissue, so viable tumor. So if we do the PET-CT, if there's avidity, that means there are viable tumor cells. Then there's a place to go for retroperitoneal lymph node dissection, because basically we are trying to avoid retroperitoneal lymph node dissection in seminomas, not
That's
like
right.
non-seminomas.
That's right. So why do you not do it with non-seminomatous tumors?
In non-seminomatous tumors, because most of the time, even if we do the retroperitoneal lymph node dissection in seminoma, we will encounter fibrosis or debris. But in non-seminomatous tumors, these are relatively poor prognosis, poorer than the seminomas, and there's a high chance for relapse, especially in the retroperitoneal region. And so it is recommended to go for retroperitoneal lymph node dissection in non-seminomas.
So there are two reasons. One reason you mentioned, because with NSGCTs, there's no point in observing these patients. But if you see a mass, just crack on and do the RPLND or give the second cycle of chemo. The other point is we're doing FDG PET. So NSGCTs are not FDG avid, so there's no point in doing FDG PET in NSGCTs. So whereas seminomas are sensitive, FDG avid, so there is a point in doing FDG PET. The interesting thing here is that mature teratomas are not FDG avid, so you will be able to differentiate whether it is a residual tumor or a sort of dying cancer cells or a mature teratoma. Yeah, that is the point there. So we don't do FDG PETs there for NSGCTs for two reasons, not only for one reason. Yeah. I don't think you need to know much about those second line and third line chemotherapy regimes, because it's not really the urologist area. It's mainly the oncologist area. If you know about BEP, that is good enough, I would say.
Yeah, in a summary, I think so the one important thing is that if you are treating a testicular cancer, staging is only done once. So that's your initial staging. You don't do a restaging after repeated imaging or repeated markers. So once you do the first bit of staging and once you first manage the patient, if the patient comes with recurrence, you only categorize them as high risk, intermediate risk, and low risk, and then carry on the protocol-based management depending on that. So you don't restage and redo for certain other things like every other cancer. So that's one important thing that we need to remember as a slightly different approach in testicular cancer.
So after the primary chemotherapy, they recommend to repeat this CTs because we had to know that there's a residual
Yeah, that's true. But
Yeah.
when the patient comes with the primary tumor, you stage the patient.
Yeah.
So after that, let's say in surveillance, he developed a retroperitoneal lymph node disease. You don't restage the patient again as a stage 2 disease or something else, right? So you
Yeah, it's managed as a
recategorize the
relapse,
patient.
yes.
Yeah, so that's
Yes.
something which you need to remember. In testicular cancer, we don't go for, all right, okay, right, this patient developed a nodal disease. Now he's stage 2. No, there's no stage migration. So you categorize them as after the initial staging as a risk category, and then manage as the risk category. So we know the criteria for the risk category. So that's an important concept in testicular cancer. The other thing is, I think most of you are aware that the S staging is considered as the post-operative tumor marker levels. That is something which I want all of you to understand. This is usually we do it post-operative after 1 week, maybe 7 days. So depending on, as you said, the T half of the tumors. So that's one of the important things. The other thing I would like to highlight is how it now, unfortunately, we haven't seen much of these MDT on these things because of our exposure is less. But in a developed world, how it is done is if you give a scenario that the patient usually comes from a primary care with a testicular lump or a testicular mass or abnormality, they come to the fast track urology clinic straight away, usually in the UK within 2 weeks. So once they come to the tertiary center for the urologist, what we do is we do an ultrasound scan and we do tumor markers. And if the ultrasound scan is suspicious of tumor, what is the usual sensitivity of an ultrasound?
We are using high frequency, more than 10 hertz
Yes.
ultrasound scan, then it's a high sensitives. I think about more than 90.
Yeah, I think it's more than 95% sensitive. And
Yeah.
then
And we always use the high frequency, 10 to 15 hertz probe for testicular ultrasound. So we don't use the low frequency because we don't need depth in the scan because it's there. It's only the skin.
So the resolution is the most important thing.
Yeah, and it is 95% sensitive. And a good ultrasonographer will tell you whether it is a seminoma or an NSGCT. Because seminoma in scan is homogeneous. You can see the testes separately, but the tumor itself is homogeneous and not much vascularity, not much necrosis, and the periphery is fairly well demarcated. Whereas NSGCT is different, very necrotic, very angry looking, lots of vascularity. So a good sonographer will be able to tell you not only that this is a tumor, whether it is likely to be a seminoma or an NSGCT. So it's more than 95% sensitive.
So in a practical setting, when you see the patient with the seminoma on the ultrasound scan, you straight away counsel the patient. So counsel him about the surgical removal because there's no usual place for biopsy. So you counsel the patient for radical orchidectomy. You don't wait until the staging investigation comes. So you don't wait until the CT chest of the pelvis. So you book them, but you don't wait until they comes, and you send the bloods, and then you straight away book them on the next available operating list. So that's very important, because why we're doing that? Because some of these tumors are rapid, because we don't know whether these patients having a teratoma or a aggressive variant. So you book them, and then you arrange the operation probably the following week if it is possible. So you do that, and then by the time your histology is ready, you get a staging cap results as well as your tumor markers, so you can have a meaningful discussion at the MDT. So these patients are usually referred to in the UK, they refer to a supra-regional MDT. So not just there are some specialized centers who specifically manage testicular cancer, because it's not everybody's bread and butter. So it's very important.
Can I add a bit
Yes.
to what you were talking
Yeah.
about? So when we were sort of preparing for FRC as Euro, we were told to mention that you will walk the patient to the CT scanner on the same day. This is how we were asked to present the case. Once you've examined and once you've diagnosed that there is a tumor in the testis, we were asked to say in the viva that I will walk the patient to the CT scanner and see whether he can get the CT chest. And if the CT chest is not available, I will get a chest X-ray for the patient and book the patient for the next available list for orchidectomy. That's how we were asked to say in the viva when the case scenario is given with testicular cancers. Just to add a few points to
Absolutely.
the point Nishanta was making.
It's very important to, I forgot about the chest X-ray. So you do the chest X-ray. If there's extensive lung metastasis, that has a significant bearing to think about going for upfront chemo. That's the only thing. So usually patients are symptomatic, and the testicular lump is usually advanced that you can see. But yeah, so
the bottom line is you need to show that you are aware that these tumors are rapidly progressing, and you don't sort of accept delays in testicular cancers and penile cancers. Delays are fairly all right with renal cancers and prostate cancers, but not with bladder, testis, and penis.
Yeah, so it's very important, these things, and mention about the MDT also. I think the other important thing is just a few about just the details when you do a retroperitoneal lymph node dissection, especially when you do a radical inguinal orchidectomy. You tend to transfix the cord by a non-absorber stitches. Do you know why it is? Devika?
Rather than usually the tissues we are putting because I can't if we want to trace proximally, so I'm not sure. But
yeah, it's that if you're going to do a retroperitoneal lymph node dissection, you're going to come from the abdomen, and you're going to trace all these sort of lymphatic structures from the abdomen, and it's just to tag the endpoint at the groin. So internal ring is the endpoint from the inside, isn't it? So there's no point going beyond the internal ring. So if you do a tagging, so you know where that's the bit of the cord which I need to remove.
is it usually done? But we are not doing with non-absorber. But I'm not.
It's a traditional teaching.
Okay.
So it's a traditional teaching. So you won't be. I mean, if somebody asks, or if there's some concern, you can tell.
And this is not very common, isn't it, Nishant? I mean, if you,
I mean, the people who
if
do
you see stage 3 disease only, you do this.
Exactly.
At the onset, if it is stage 3 only, you do this. If it is not stage 3, you don't have to do this.
Yeah, and the other thing of clamping the cord is also, I think it's an old teaching. So that's but these things can appear. So that's one of the important things. And the other thing which I think we didn't touch upon is let's say somebody comes with subfertility workup and ultimately ended up with a testicular biopsy, which shows germ cell neoplasia. So how do you tackle this sort of scenario? These are a bit uncommon, but you can see that these
So
things
germ
are
cell
very common.
germ cell neoplasia in situ, the problem is the future malignancy. So it's and but treat.
Can you quote some figures?
Sorry, sir.
Can you quote some figures of future malignancy risk?
It's about
It's about
50% in next.
50% in 5 years time. 5-year risk of malignancy about 50%.
Yeah, so 50% in 5 years and 70% in 7 years. Very easy to remember, right? So
And so treating can be, the management can be either surveillance, or you can go for a radiotherapy, or you can go for a prophylactic orchidectomy. But I think because of this subfertility, I will explain the patient about the options available and the associated subfertility also. I would personally go for surveillance because he's already, I will do a seminal fluid analysis also. But at the same time, I will examine the other testicle, and I would go for surveillance.
yeah, as Supun said, these are typical testicular dysgenesis spectrum, isn't it? So they come with subfertility, line of management, and then you do a testicular biopsy at some point, and then you find to have a germ cell neoplasia. So yeah, as you said, if there is a fertility concern, you go for extensive surveillance, and the other options available, you need to discuss the options. So the common treatment option which is available for patients who have got no concerns about the fertility is to give a single dose radiotherapy, 20 gray single dose, which is curative. And the other option is chemotherapy, but chemotherapy has a curative rate of only 2/3 of patients will get cured with chemotherapy. So about 1/3, you still need, after chemotherapy, you will need a bit of a surveillance for them. And upfront orchidectomy is another option. So surveillance, yeah, we discussed about all these things. So that's about that. The other thing is, do you know anything about the testicular microlithiasis? That's another thing which can
It is a
appear.
risk factor for, it is a risk factor for this James testicular in situ tumor and also the testicular cancer.
Is it?
It is a sorry, association, not a risk factor.
Yeah, it's an association. It can be an
Yeah.
association. It's not a risk factor. It's a historical thing. So nowadays, so read about what is considered as microlithiasis. There is a quantifying way that how many calcifications in that particular window of your measurement. And of course, I think the answer is if there are no concerns of testicular dysgenesis, well, of course, if there are any evidence of testicular dysgenesis, yes, there is an increased risk of developing testicular cancer, but just the pure incidental microcalcification, there is no need to follow up if there's no risk factors of dysgenesis, and there's no need to biopsy.
Yeah,
Anything?
I think there was only one paper in all of the literature saying that there is an association or a well, in that paper says that there was a strong association of microlithiasis to the testicular cancers, but there were several other papers following that disproving this fact. So at the moment, as per the knowledge today, we don't believe that there is an association between testicular microlithiasis and testicular cancer.
Yeah. The other thing which we couldn't discuss is about the testicular prosthesis.
Yeah, testicular. You can go for a at this time of orchidectomy, you can go for a delayed orchidopex prosthesis insertion. Because there was a concern at putting at the time of orchidectomy that there was increased risk for this infection and chemotherapy related, because if we are planning adjuvant chemotherapy, chemotherapy can cause immunosuppression, and there's increased risk for infection. There was a concern, but again, both options are there. You can go for either at the same time or delay.
Yeah, that's
What
right.
would you do?
Yes. What would you do?
I would go for delayed prosthesis. Especially if it is a young patient, if I'm planning adjuvant chemotherapy, especially if there's a because I don't know about the histology, so without histology, probably if it is a young patient, and if I might go for a adjuvant chemotherapy, so I will consider delayed.
So the
Prosthesis
thing is
insertion.
now here, the advantage of doing it at the time of the orchidectomy is you are doing the operation with an inguinal incision, whether it is inguinal or subinguinal, and when you deliver, and it's a bit more sterile than the scrotum and the groin.
Okay.
So the introduction is easy. Just need to put an anchoring stitch and push it in, and that's it. If you are doing later on, then you have to go through the scrotal skin, which is not as clean as your inguinal skin, you know. So there are pros and cons, and there is no absolute difference between the two approaches as far as I'm aware, and both approaches are well accepted. But have a set answer if this is asked from you, and be able to rationalize what you are doing with solid answers. You know, both has its pros and cons.
Exactly. You just need to, you don't have to take a decision. You just have to mention these are the pros and these are the cons, and I'll have a meaningful discussion with the patient about what he thinks about it, and especially if the patients have other risk factors like poorly controlled diabetes and other concerns. Well, of course, then you will highlight particularly that there is a risk of wound infection and a prosthesis infection. But other than that, I mean, it's easy to do it. And especially if the patient is young, he's got some cosmesis concerns, it's more important you discuss this with the patient and document it than doing it or not doing it. That's it. You give the patient the option. And the other thing is, yeah, if you are doing it, again, you need to counsel infection. And the other thing is the exclusion. It can come out and it can migrate. And also, patient may not be happy. We have seen some patients who are not happy with the size, and they will come and complain about the size disparity. Other side may be larger or smaller than the prosthesis. So you need to think about all these. So nowadays we have I think the PVC prosthesis is much commoner and accessible in our country, in Sri Lanka, but in the other places there are saline filled prostheses which are more realistic compared to the PVC. So that's that. Have you got any other questions or anything important? I don't know. I think we have discussed many things.
If anyone has any questions about the topic, we're here to answer.
You just
for
need
the
to
contralateral,
yeah, go ahead.
For the contralateral testicular biopsy, why can't we go for true cut biopsy?
I didn't say that we can't go for that.
Yeah, you
Both
can.
options are there. But I mean, as I said, when it comes to this kind of points, you need to have a set answer, because there are no rights and wrongs here. You need to tell the examiner what you're doing, not what the others are doing. So what I would do is I would do the orchidectomy and do a scrotal incision on the other side and do a open biopsy. where everything is
They say
under.
from two sides, right?
Yeah,
Yeah,
so
absolutely. Yeah.
so
So, the advantage is that everything is done under direct vision. Well, the test is biopsy is pretty easy with the TrueCut. But sometimes if you go through the seminal vesic, the rete testis or the epididymis, then there can be sperm leaks and all sorts of other problems, which is very rarely seen. But my approach will be open approach. So
So
I
in
didn't say
that
that TrueCut is not acceptable.
So in that case, if we are dealing with the inconclusive small tumor, other than the partial or testis preserving surgery or sparing preserving surgery, can we go for a biopsy before planning a partial or testicle preserving surgery? If it
Are you
is a
talking
small
about
inconclusive
are you
tumor.
talking about the primary tumor?
the tumor.
Yeah, primary tumor.
We
Uh,
that isn't it?
Well, I haven't seen anywhere it is advised because you have a fairly normal contralateral testis and you
Not
don't
So
with
if you
lose.
look at the indications for partial locudectomy,
yeah.
inconclusive small lesion is an indication for partial.
But if it is inconclusive, the tumor markers are normal. But still,
So
if
what
it
you
is
need to
inconclusive,
understand is partial orchidectomy is a little bit more than a biopsy.
Yeah.
It's not far from doing a open testicular biopsy, the partial orchidectomy. So there's not much difference between the two.
Yeah, and
So
if you
why not straight away go ahead
look
and
at the
do partial
indication
orchidectomy?
also, even if the patient's got a single testis, the indication for a partial orchidectomy of a single testis is if the patient is having normal testosterone level, because you're not worried about the fertility. So you're just worried about the endocrine function, whether you need to get the patient into a endocrine injection dependent, isn't it? So your worry is basically the endocrine function. I think, yeah, the biopsy of the tumor itself is not, I haven't seen it anywhere, as Supun said. So you can do a partial if it is like, as you said, this is really a very high sensitivity in the ultrasound. So if the ultrasound says very, very unlikely, so you can have a chat with the patient, see whether what his wishes and what the age of the patient and everything. And then you consider going for a radical orchidectomy or a partial if it is really, really inconclusive. And the
I would
marker,
say that it is a very, I would say it is a very hypothetical scenario, and it's
yeah.
very
And the
rarely we come
markers
across that.
don't ever depend on the markers. So I have seen many people, non-urologists who are practicing, has reassured patients in my practice. I have seen many who've been sent home saying that, oh, you've got a bit of a lesion in the testis in the ultrasound pan, but don't worry, the markers are negative. So I've seen that. So don't go with the idea ever that the markers are going to be around 50% or less. So the tumors may be negative for markers. Yeah, the other important thing in the historically, if you look at, since you've discussed extensively about the chemotherapy, from 1970s onward, there's a significant improvement in the survival of the testicular cancer, and that's because of one factor, and that factor is cisplatin-based chemotherapy, so platinum chemotherapy.
Yeah.
So
it's not because we are getting better. It's
yeah.
The credit should go to the oncologist.
Yeah. And I think rather than going through quite an extensive regimes of everything, just to know some of the common side effect of these chemotherapy. So bleomycin, lung toxicity, cisplatin neurotoxicity, and the renal toxicity. Those things are much more important than going through extensive regimes, and have a very simple way to work out. Like, stage 2, this is my protocol. Stage 3, this is my protocol. and then have some understanding about the risk stratification, and they can appear, sometimes can appear in MCQs. So yeah, I think the initial bits are very important about these histology markers and things. They can always, it's a very favorite MCQ question. You need to know in and out about the markers and things. So they can ask so many questions with the markers. So that's very important to.
And the stage 1 disease, isn't it? Stage 1 disease.
That's what we manage.
Yeah.
So, yeah, and the TNM, don't forget about the TNM classification. So it's very important how to sort of, it could be asked in the exam. So what particular stage is this patient's tumor? So remember all these TNM classification, remember it and write it before you go to the exam and have a rough idea about everything. Anything else, Chaminda? Are we okay? Or
So then, before winding up the session, I would like to thank our expert panel, and as well as all the presenters and all the participants. And apart from that, also I would like to thank CIPLA group, where the people who have provided this platform to discuss this wonderful session. So I would like to tell and winding up the session now, and good night for.
right. Thank you very much.